Hello, good morning, good afternoon, good evening, everyone. I'm Dr. Stephen Conner, Executive Director of the Worldwide Hospice Palliative Care Alliance and co-host of today's webinar. I want to thank our co-hosts for this session, the Russian Palliative Hospice Care Professionals Association, the European Association for Palliative Care, the American Eurasia Cancer Alliance, PACE, and of course, WHPCA. We're gathered here today in advance of the main EAPC conference to celebrate World Hospice and Palliative Care Day, which is this year, the theme of which is leaving no one behind, equity and access to palliative care. And we certainly experienced inequities around the world in access to palliative care, and including the CIS countries and Eurasia region. We are going to have a series of sessions, presentations to share with you progress that's being made within the region to overcome these inequities. And we welcome your participation. And at the end, we wish to agree a declaration from the CIS countries on the need for palliative care. So with that, I'll turn it over to my co-host, Diana Nezrova. Diana?
A very good afternoon, good morning, good evening, dear colleagues, depending on where you are. It's a pleasure. Allow me, please, to welcome you at this surprising and very festive and much awaited online meeting. I would first and foremost would like to thank the European Association of Palliative Care for making it possible so that we should make it open and for everyone. I would like to thank our distinguished co-chair, Stephen, for giving us this idea to run this session. So, dear colleagues, today we'll be discussing how palliative care is evolving in our countries, in the post-Soviet space and CIS countries. It's a very important and very moving subject. And I would very much like you to please first of all, welcome you and thank you for being with us. Allow me please now to give the floor to Julie Ling, who is Chief Executive Officer of the European Association for Palliative Care. The floor is yours, Julia, please.
Thank you, Diana. It's great to see so many people already online, and we'd like to welcome our colleagues from CIS, and we're really looking forward to working with you. It's great to have this opportunity to learn from each other. This meeting has been planned for many years. We originally hoped it would take place in person in Helsinki. Unfortunately, due to COVID, we weren't able to do that, but we really hope that this will become a regular feature of our EAPC congresses going forward, and so that we truly are one voice, one vision for Europe. So I'm looking forward to the Congress today and to hearing all about your developments in the various countries around CIS. So thank you very much, and I wish you all well with the conference.
Allow me please now to give the floor. Allow me please to give the floor to Eric Krakauer, Director of Global Palliative Care Program in the Division of Palliative Care and Geriatrics at Massachusetts General Hospital, Associate Professor of Medicine and of Global Health and Social Medicine at Harvard Medical School. Eric, the floor is yours.
Thank you, Dr. Nevzorova, and hello to everyone across the Russian Federation and CIS countries. It's really a pleasure to be with you and for this event finally to happen. Thanks to Dr. Nevzorova and the Hospice Care Professionals Association. Also, thanks to the World Health Organization country office in the Russian Federation, Dr. Melita Voinovich and Dr. Elena Urasova, thanks to the Federal Center of Palliative Care at Sechenov University, and also to the European Association of Palliative Care and Dr. Julie Ling. Thank you for all of you for making this happen. I think this is a very important event for people who suffer from serious illnesses across CIS countries, and for those who care for them. palliative care needs vary by location, by socioeconomic situation, by the clinical situation, and by culture. And we know that cultures vary a lot across CIS. But many people from many CIS countries are in Russia, and the Russian language is shared across CIS. So I think that this is a very important event wherein palliative care clinicians and organizations and advocates from throughout the CIS countries can meet, can learn from each other, can teach each other, and can support each other, and perhaps even begin consideration of a CIS palliative care organization. So a very exciting moment. Thank you for inviting me to participate. Thank you.
Dear colleagues, Sophia Michelson now has the floor, who is Executive Director of American Eurasian Cancer Alliance. Sophia, the floor is yours. Thank you very much, Diana Vladimirovna. It's a pleasure, such a pleasure to be part of this program and this event. The American Eurasian Oncological Alliance holds programs in Russia and CIS countries and has been doing it for the last 25 years, but only over the last 10 years, I've been working for provision and development of palliative care. I would like to thank all the organizers of this particular event, but my special thanks to one person in person who brought me to palliative care. Her name is Gulnara Kunirova from Kazakhstan. As she worked from the organization Together Against Cancer, I started my first program in Malta, in Kazakhstan. I would also like to extend my thanks to my great friend, partner, and colleague Diana Nigzarova, who chairs the board of the Hospice Care Professional Association in Russia, who gave me so much in terms of wonderful moments we shared together, where over the last several years, we've been truly involving international participation, began to plan amazing projects. And these projects are now running, and we will be able to discuss them now. We can share how we are executing them with all the stakeholders and participants of this Congress, both from Russia as well as for invited countries. I'm so happy to see my friends from CIS, from Belarus, from Tajikistan, Uzbekistan, from Moldova, and it is a great pleasure to be with you. I wish you all well at this wonderful session.
So, Diane, go ahead with the rest of the start of the program. Thank you.
So, dear colleagues, and it is such an exciting moment, and it's so, I do not have any feeling that we are on Zoom, that we're online. I have a feeling as if we are sitting next to each other, to one another, and today we'll be discussing those changes, amendments, those way that that path that we traveled over the last decades with our friends and colleagues. And it's important that we have drafted a declaration that we would like you to familiarize with. It is available for downloading at Zoom session. We would like this declaration to stay after this meeting is over. Why? Because we have done so much over the last several decades in our countries to improve care for patients who are suffering from incurable diseases, be they children, be they adults, be they their family members, near and dear. We made it possible, at least we think so, to care for them. But we perfectly realize that barriers are in place, difficulties are in place, and we find it difficult, each of us, to try to tackle them alone. But we each have best practices. And it is since 2017 that the level of palliative care in some post-Soviet countries and CS countries has been estimated as level 4A. It's fantastic because they are the countries who could make tremendous progress and took serious steps to integrate palliative care and prepare everything to integrate palliative care into the healthcare systems, national healthcare systems, who have traveled a long way. But unfortunately, in recent years, the measures that were adopted probably were insufficient to make sure that all who need help should get it fully from professionals the way they need it. So if we speak about the Russian Federation, well, it has seen several serious steps to improve, first, access to palliative care. And we have finalized legal framework to make sure it is all taken care of. We took steps to ensure that new formulations of drugs would become available. And what is also important, we are now seeing something that was not available, that is oral and non-invasive morphine. This is now available everywhere. We have seriously amended legal framework within the country from these opioid drugs. There is not one single region in Russian Federation who does not have a hospital or outpatient setting for palliative care. Much was done by NGOs, non-for-profits, by charities and private beneficiaries who became the true engines to drive these palliative care forward, to integrate it into national policies and national healthcare. This path that we traveled testifies that these barriers that now stop us in our progress need to be tackled. That is why, as we say, time has come for more closer cooperation between professional and non-for-profits who provide palliative care within CIS. It is an open secret that we every day are in touch, both in terms of how to provide care for patients when the patients move, say, from one country to another, when healthcare professionals may be changing location they stay and work at, when we realize that we're colleagues, friends, and comrades in arms, if you will, ideologically, in this front line of fighting for the needs of our patients. So we would like to show you those mechanisms that we adopted here in the Russian Federation, certainly under the great influence of NGOs, of charities, associations, and dear colleagues, let's discuss these guidelines and what is going on in our countries so that we could try to come forward with some specific steps, concrete steps that would enhance to the best standard what we can do to help our patients in what we can do. Without further ado, I would like to give the floor to my distinguished colleagues, those colleagues who have been working with us as one team. This is the Hospice Care Professional Association in Russia, those who work across Russia. And I would first like to give the floor to Helena Polivichenko, who is Chief Specialist on Pediatric Palliative Care in Russia, Doctor of Medical Science, who is Professor of Oncology, Hematology and Radiation Therapy of Pirogov Russian National Research Medical University, and she sits on board of the Hospice Care Professionals Association. Helena, the floor is yours. Thank you so much. I would like to thank first the organizers for giving me the floor. This day is truly important for me. And what I need to do over 10 minutes to squeeze into 10 minutes what we've done over 10 years about palliative care to children in Russia. I will try to do it. The first steps in Russia were taken back in 2010, after a very long story, after palliative care has been evolving in Europe. In 2010, St. Petersburg hosted the opening of the first pediatric hospital in Russia. Next year, on the following year, a very popular paper by Knapp showed us that this is the way the world sees our country, as level 2 out of all 4 possible levels. This is what it looked like 10 years ago. I've demonstrated this slide, I don't know, dozens of times, and it is my pleasure to show it to you here again, saying that it is completely obsolete, completely outdated. We're no longer at level 2, which we were at 10 years ago. We've been developing and we've been evolving. The state, the public sector provides us a very solid support and has been giving us by adopting legal acts that, starting with 2011 up until now, have been regularly updated and amended. The key was a federal law adopted back in 2011 with the first legally acknowledged palliative care And one can't underestimate the role of non-for-profits in charities, including pediatric palliative care, that using international methodology, together with the National Center of Russia for the Healthcare of Children, estimated the needs of the pediatric population in specialist palliative care. What you can see here is as of 2015, the needs were identified over 80,000 840s, on average 10 by 10,000 pediatric population, which is well comparable with the average European need. Over the year that went by, unfortunately, not every child that needed it, as according to our estimates, we did not provide it to each and everyone. I would much rather say that palliative care in Russia nowadays is given as a child is identified as needing, but nobody is working proactively to identify them. But whatever, 19,000 children who were recipients of palliative care in Russia, as everywhere in the world, neurology accounts for most, we consider it as a huge step forward. And may I share with you the number of beds to provide pediatric palliative care across Russia? In the first 6 months of 2021, there were 1,100 across Russia. And this is alongside these constituent entities of Russia, federal districts. This is pediatric palliative care that is provided via outpatient mobile units. These units may have more than one team working with it, but overall now we have about 190 across Russia. And I would like to highlight that over these 10 years in Russia, apart from that very first pediatric hospital that was opened in St. Pete, I suppose now every federal district has a hospice at least. We have 12, and each of them work very closely and tightly with our Association of Hospice Care Professionals. Well, you can see here in this slide the statistics, how different are Russian territories in federal districts in terms of whether mobile units are available there. You see that because of remote landmass, geography doesn't play the paramount role. Children from, say, Siberia and Russia's Far East may have greater access to mobile units rather than, say, in central Russia. No time, unfortunately, to comment about it, but on average, the number of pediatric mobile units in Russia is 0.883 per 50,000 pediatric population. Respiratory support has been going by leaps and starts in Russia. You see that as of early 2021, in the first 6 months of this year, we have 1,272 children on respiratory support at home. And apart from that, nevertheless, are there those typical problems that we everywhere have about palliative care? But what matters most is the dominant problem of how to integrate between primary and specialist care. Both are there now taken care of in our legal framework, but what matters mostly for Russia and post-Soviet space countries is how to integrate with pediatric specialists. The thing is that Russian, or rather Soviet medical education, thought that pediatric medical schools where freshmen would go, will start specializing in pediatric care, being just a first-year medical school student. And this certainly is reflected in our structure, how things work in Russian medical care. This is just a schema, how a child who needs palliative care, he is just somewhere stuck between these two spheres. And the hugest and most important objective, which we're struggling to take care of, is how to integrate the efforts of these two services to serve the interests of a child. I've been borrowing largely, I should say, on comics, on these cartoons, that the model of integration of disease modifying and palliative care, we are certainly there, but we are struggling actually, we're stumbling on this way. What makes us special? The thing is that in Russia, and this is probably typical of many countries of CIS who are listening to us, we have a huge number of pediatricians who were trained and are still being trained in such a way at pediatric medical schools And we must find a way to communicate and find a key to tackle, to sort of be in touch with their heart and mind, if you allow me to put it this way. What I'm happy with that we can now track and we can make sure nowadays that professional standards, national professional standards for specialists who work in pediatric care, now adopted competencies in providing palliative care. These are the names of professional standards of national specialties where, when they are trained in medical schools, they learn how to provide primary palliative care to children. Several words on education. I know there will be a dedicated report on this, but I may highlight that in my university, we were the first in March 2014. Two departments have been conducting specialist training course for pediatric palliative care, for PPC. And 6 medical universities now adopted teaching these courses on average twice a year. Some may teach it more or less often, whatever. This is an average, but we seek to adopt universal one-size-fits-all standard curriculum and teaching process. I would like to highlight that in a number of CIS countries, they still have pediatric medical schools where children come as fresh, or rather students come as fresh men and fresh women, sort of first-year medical students, and they are taught in this sort of specialist medical education. But I think it is good for us because to make sure those universities that attend this meeting, this is the founding year they started, we can integrate and move forward standardizing teaching competencies and one-size-fits-all curriculum. Several wrapping up remarks. Fantastic paper in Cancer 2020, where they showed whether the ideas of CIS countries professionals, whether the ideas of what they do are in line with what WHO think is needed for early integration of palliative care in cancer, and specialist cancer care. You see, the more red you see on this, it means the closer they are towards WHO posits in guidelines. You see how much has to be done to make sure we adopt a single standard. So as I'm wrapping up, I would highlight what we see as the most important problems in Russia. We need to strengthen Russian legal framework to palliative care in general and to children in particular. We must standardize and adopt single or universal standards for teaching palliative care and using the drugs and medications that are recognized in the formulary as the ones that are needed for pediatric palliative care. We must ensure support, including methodological support for methodology. Apologies, yes, your time is up. And we must adopt evidence-based medicine. And this is something we've been doing following the national guidelines, clinical guidelines. Thank you so much for your attention. Helena Vladimirovna, thank you so much. Allow me please to give the floor to Guzel Aguzarova, who is Chief Specialist from the Center of Palliative Care to Cancer Patients in Herzen, Cancer Oncology Institute, Pain Relief in Russian Federation. What is the progress and what are the prospects? Thank you. Dear colleagues, thank you so much for giving me the floor at this very representative meeting. I am Guzel Aguzarova. I'm the head of the Center for PC Care in Moscow Oncology Institute, named after Herzen. In my presentation today, we'll discuss availability and access of opioids and analgesics in Russia. It is universally accepted that it is opioid analgesia that is the key to pain relief in oncology and in palliative care at large. This is an axiom that is set up in all the guidelines on pain killing. Not so long ago, back in 2007, well, difficult to imagine, but Russia ranked number 38 out of 42 European countries in terms of low consumption of opioids per 1 million population. Our general level of usage of opioids at that time was only 107 daily units, SCCD. The list of SPDDD, the list was pretty short, only 2 strong opioids available at that time, patches, fentanyl patches, and the extended release morphine available at that time. We also had tramadol in caps and in pills, but it's clear that in poor access was pretty poor. How could we address this problem? How to make work on availability in providing access to painkillers in healthcare? I like very much slide that is shared with us by Jim Cleary. It identifies the needs, the reasons for poor availability, and possible ways how to tackle this problem. First and foremost, one should start with changing the politics, changing the policy at the national level. At this stage, the most important driving force were socially focused non-for-profits, NGOs. They are charities. Vira, which stands for faith in Russian, Gift of Life, Pediatric charity, Child Palliative charity, they made it known to the government officials and they could drive public support through public awareness campaigns. And this kick-started the process. Well, in 2016, this came to a situation where the chairman of the Russian government at that time, Dmitry Anatolyevich Medvedev, officially signed action plan known as Roadmap. It was known increasing the availability of narcotic drugs and psychotropic substances for medical use. It was a huge victory. It was a huge step forward. This roadmap had the following objectives: how to expand the range of narcotic medications available, how to optimize the methodology to estimate the needs, how to ensure access and availability of pain relief, to make more simple prescription. Most importantly was decriminalization of medical and pharmaceutical staff when they worked with narcotic drugs, how to further evolve the legal framework, and how to provide further development of palliative care, and how to train medical professionals in using opioids in pain relief. In 2019, most serious amendments were made into the federal law on health care for Russian citizens. Nowadays, it lays down the right of the patient, irrespective of their diagnosis, irrespective of their condition, irrespective of the place they live in. It ensures access and availability of methods and medications, including narcotic drugs. The new version of the law has considerably expanded access and availability, which helps ensure adequate pain control. And now the list of non-invasive pain relief drugs went from 4 to 14 names. They're both tablets and pills and sublingual pills as well as patches. The thing is that the majority of these drugs, 8 out of 14, Russia has been making here locally at Moscow Endocrine Factory. And now only 4 per-use morphine, non-invasive per-use formulations, and 2 that are fast-acting, which is most important for palliative patients with strong pain, which is immediately reflected in WHO guidelines. The precondition, the sine qua non for palliative care. Moreover, this factory is prepared to provide them to ship to CIS countries. So in 2 years after that, Moscow Endocrine Plant promised that they will be making new formulations, patches, pills of immediate fast-acting pills, and they were made both for pediatric and adult formulations too. At our oncology research institute named after Herzen, where I have the pleasure of working, since 2014, we have adopted novel technology, how to put in place intrathecal morphine pumps for patients with especially severe pain. Now we have put in place over 210 pumps. It is all free of charge for Russian citizens. Every year, the government is allocating about 60 million euro about 60 million euro per year, each year, to further provide the needs of palliative care. This also is something where we pay for opioid analgesics for the needs of Russian citizens. That's why opioids for all Russian citizens are issued free of charge. Because of these changes, we are seeing soaring use of non-invasive opioids in Russia. Just look on average across the country. Look at this graph. Over the last 10 years, the consumption has grown tenfold. So we can sum up that 2 out of 3 problems that we faced at that time, we tackled them successfully, or at least we have traveled a considerable way. But you will hear later in further presentations what we do in terms of education and training. What I would like to say that a lot of caring and working physicians, starting with groundwork physicians, including top government officials, still have to travel a long way, but we must say that we laid a foundation in place to make these plans come true in every area, be it policy, legal, financial, educational, or socio-cultural areas. Of course, there's a lot of work ahead of us, and I'm sure we'll be seeing many problems. So may I quote our outstanding American anthropologist Margaret Mead, who said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Moreover, this is the only thing that ever has done it." So, and our example really serves as a testimony of this. Thank you very much. My presentation over. I wish you all success and very good health. Thank you. Guzel, thank you so much for this presentation. The path that we traveled, seeking to improve pain relief, is probably the most difficult, the most needed, and probably the most difficult road we traveled. Of course, we haven't yet reached our destination. A lot has to be done. Many amendments have to be made, but we'll discuss it further on. Dear colleagues, allow me please now to give the floor to Olga Ositrova, who is Chief Physician of Samara Hospice, Chief Specialist on Palliative Care in Volga Federal District. She sits on the board of Hospice Care Professionals Association here. We're speaking about life support technology and how respiratory support has been evolving in Russia. Olga, you now have the floor. A very good afternoon, dear colleagues. It is indeed just an incredibly touching moment for me to see you all online. May I share how respiratory support works at home in Russia. This is something pretty novel for, probably not for Russia, but for the world at large. For patients with respiratory failure, we do know that in a large number of many diseases, we see respiratory failure. And this has always been a huge problem because, of course, if a patient is in hospital setting, this certainly changes their quality of life. But when we provide care at home, this matters so much for the family and his near and dear, and those who take care of him. But still, it's important for the healthcare system at large too. Why? Because this really takes a lot of economic burden because it sets the beds free for other patients who cannot be cared for at home. But the quality of life of patients who have been on respiratory support for a long time, well, is changing incredibly, really. In most countries, respiratory support at home is provided not only when they get already palliative. This is given to other patients who need specialist care. Whereas in Russia, things work a little bit in a different way because our situation differs in a sense that respiratory support at home evolved and first appeared in Russia as part and parcel of palliative care. How did this happen? In the early 2000s, respiratory support at home was only provided to just anecdotal cases across Russia, just less than a dozen patients from St. Pete, who for 7 years, well, she was a translator who worked from home, translating medical literature, and only a handful of specialists knew how to provide respiratory support at home. It was rather an exception, not a rule. But this situation began to change thanks to foundations. They are non-for-profits, non-government organizations that helped in cared for severe patients, not only during on therapy, but when all were exhausted, when the children or patients would be getting to ICU. This is when we saw things changing. And the first pilot project ran in 2016. Whoever should tell us today, but back in 2016, that was breakthrough year for Russia, although of course it took a lot of effort and work to make it possible. The first pilot project ran in 2016 when 32 children from all across Russia were switched to respiratory support at home. This came as a huge step forward. And what are the results of this stage 2 of what we've been doing? Collaboration of charities, foundations, associations, and hospice care made these changes possible, first of all, in public mind. The first guidelines and recommendations were adopted. First clinical trials and other trials ran over 700 people, 7 to zeros, as of 2016 were on respiratory support, given that they have respiratory failure, at home. This is a significant figure, given that where the public sector was involved in just supporting 32 children. Well, nowadays we are in step 3 or phase 3. As of 2016, we're now seeing system-wide changes at every level, be it legislative level, funding that is made possible by the public sector, monitoring and evaluation. We have seen significant changes here and amendments. Let me just tackle the 2 most important changes. A federal law on healthcare to Russian citizens for the first time laid down the right to medical devices, to support life-supporting medical devices at home. That was a groundbreaking rule. And as of today, we have adopted a full set of regulatory documents about what sort of medical equipments, how they should be moved to patients' home, how they should be organized. So every region now has down-to-earth, practical, step-by-step ways how to sort of travel this way, how to include this care in their everyday activities. What played a huge importance that for the first time in federal law number 345, they identified a novel algorithm or structure for that is known as a respiratory center that were set up across Russia. Funding. What's important that public sector funding, it's when we see it by breakdown, we see that for most part, the equipment that is needed for respiratory support is procured to make sure that the patients receive them at home. What are the deliverables? What are the outcomes? Since it's high-cost equipment, so as we said, about 70% of all expenditures and all subsidies to the Russian regions go to pay for these high-cost equipment. But this is something that made it possible over these 6 years. We only had 700 patients, as I said, but in the last 4 years, we have seen soaring figures. Over 6,000 patients went back home and got respiratory support there. And as we see it, we are seeing very many difficulties, of course, as we travel, because Russia is huge by landmass. It's huge. And the distances everyone has to travel like we're seeing such difficulties, few specialists who have full command and who know all the skills, long distance to travel in their qualification level may differ greatly, very much like in pediatric care in general. So difficulties in terms of technical support and availability for 24 hours a day. This is certainly there, we acknowledge that, but what is ahead of us? What are the next steps? The most important thing that we need to integrate and adopt the principles of palliative care in ICU units. Of course, studies, trials are needed, planning. That is just fledgling in Russia. We're just taking the very first steps. And for sure, the role of the association, of this association, of the foundations, of charities is truly priceless. And it could not have happened without their and our support, because they worked hard to develop methodology. They worked hard to make sure we have QC, quality control, to make sure that we satisfy the needs of those who need medical care. They were the trailblazers, and we've been doing it together. Thank you very much, colleagues, for being with us. Thank you, Olga. Thank you so much. Thank you. Dear colleagues, let's move ahead. Alexander Sidorov, who will discuss how to train palliative care, how to integrate a course on teaching. He is Doctor of Medical Science in charge of the department in Yaroslavl Medical University, who works for the Federal Center of Palliative Care. Alexander, the floor is yours. Thank you very much, dear colleagues. Pleasure to welcome you, all those who care for this. It's a great honor to take part in this event. And in my 10 minutes, I will try to discuss how education works in terms of teaching palliative care. I'd like to say that we don't have a dedicated specialty known as palliative care or physician of palliative care. It is just a position that a doctor holds, and they follow the national professional standard that was adopted pretty recently, 2018. Of course, like basic knowledge about the palliative care is taught to undergraduate students. The thing is that federal educational standards of next generation are focused on competencies. In these competencies are discussed in national professional standards, for example, general practitioner, district general practitioner, and this discusses what has to be taught. We need to teach how to provide palliative care in close cooperation with specialists and subspecialists in other medical specialties. For sure, the main burden that lies on the doctor who works in palliative care in terms of education, it's what a doctor learns in what we know as postgraduate medical education in Russia. And possibilities vary, because this can be taught not only by universities, be it in Moscow, Sechenov, Pirogov, and Ruden. This is taught in Samara, Yekaterinburg, and Perm, who teach and train on palliative care. In the same way, nurses that are taught at specialist courses under the universities, under Ruden, People's Friendship University of Russia in Moscow, in colleges, in non-for-profits, autonomous non-for-profits. This slide lists those institutions. Besides, you can train at specialist training centers that work under foundations. For example, what is known is in Kazan, Tatarstan, Angela Vavilova Foundation provides training. This opens further opportunities. We need to discuss continuous medical education here too. We have set up a specialist portal online where very many courses on palliative care are provided, both for adult patients as well as pediatric patients. And this educational track may be traveled by physicians who will be studying them independently and will be getting credits for this and will use it as proof of their medical qualification. Well, diverse training courses are taught by Association of Palliative Hospice Care. Every year, major conferences for physicians, which are followed by national congresses and conferences for nurses. They have been held annually since 2015. So over 4,000 physicians and nurses have taken part there as delegates. They've been actively working in these fora. Besides, regional fora also work under the auspices of the association. As you know, since 2016, it was attended by over 10,000 participants. Dedicated specialist palliative care sessions are held at major cancer conferences, the White Nights that St. Petersburg hosts in late spring, early summer, an international forum on oncology and radiology for life that has been held now for the third time in 2020. And at this forum, we have dedicated sessions that discuss palliative care only, where we very actively work. We have printed publications, a lot of useful information. This is a journal of two associations of hospice care professionals and Pallium, as well as Russian Association of Palliative Care, Palliative Medicine. This is another journal. These two specialist journals are available both in print as well as online as specialist medical websites. They're very popular. Media resources are widely available, huge data libraries, articles, papers, publications, video, films on how to provide palliative care both to adults and to children. You can see this on this slide. A huge event for us was setting up back in 2019 a federal Center for Scientific Research and Practical Center for Palliative Care at Sechenov University. It was mentioned many times. It's led by Dr. Nevzorova. She's the chief expert on palliative care in Russian Ministry of Healthcare, and a part of many things that the center do, educational activity are paramount importance. They hold seminars, case studies, specialist training courses, and online discussion of cases that we've been discussing jointly with our colleagues, foreign colleagues, our friends, and have been held for over a year now. And at these case studies, we've been discussing most interesting cases. Of course, they are mailed out well ahead. And then these recordings are posted at YouTube and on our website. Quite recently, in the late 2020, well, unfortunately, we hosted it online because of COVID pandemic. We taught a first national training course on teaching trainers, so TOT course, where we taught to 22 teachers from all across Russia who attended this course that was organized by this association with a very active support of WHO Regional Office. You see the screen, both of the teachers and the students. So it was a two-week course, and we plan to continue this. It's interesting to us to analyze our heroic efforts in terms of teaching palliative care, and we've been analyzing it in one of the projects that seeks to evaluate the feedback we get from our physicians. We analyzed about 200,000 questionnaires who enrolled to online course of teaching how to manage chronic pain in terms of basic knowledge that was needed before you start this course, like refresher course, and the difficulties that are most typical, these problems that are most typical, that pose greatest difficulty to physicians, and we evaluated how successful they were. You can see that out of 100,000 for each module, there were two, like refresher and dedicated course. The overwhelming majority finished them successfully. Sorry, your time is up. Well, I've only used 5 minutes. So the most difficult questions had to do with diagnosis of neuropathic pain, pathogenesis of chronic pain, and how to treat it. And as a wrap-up slide, not to discuss self-evident things like we're still together, and this is great. I'd like to send my best regards to all the attendees, and please don't be hurt. It is today Kazakhstan. Special thanks to Kazakhstan and Baikonur, and to Belarus and Minsk, to the United Belarus Institute, who back in 1941 laid the foundation. They both, when they were evacuated to the Yaroslavl Medical University. Thank you, dear colleagues. We finished our block on Russian presentations. Stephen, the floor is yours now.
Thank you, Diana. And this has been really very interesting, and just to hear the progress being made in the Russian Federation is important, because those colleagues working in the other CIS countries still look to Russia for the kind of guidance overall in terms of palliative care development. So I think it offers the possibility of helping boost some of the efforts to address these problems that there's been success in the Russian Federation: access to medicine, improvement in education, but particularly a demonstration of support from government, political and financial support from government. So we're now going to shift over to the other countries in the region, and we're going to have just a sampling really of the countries, starting with Belarus. And our colleague Olga Michko, head of the Department of Planning and Organization for Palliative Care at the National Cancer Center, named after Alexandrov. She's chief specialist of the Ministry of Health of the Republic of Belarus for palliative care, and former secretary of the Belarus Red Cross Society. And I've met Olga in Minsk, and I can say that she is a real champion for palliative care. Olga, over to you. Olga, you have to unmute. There you
go. Dear colleagues, a very good afternoon. It's a pleasure to see you all online. I apologize for missing 5 years. Those who know me, I've met you all, and a lot that I fondly recall the time we worked together. Well, to my 8 minutes, I would much rather this 16-year-long experience of working in palliative care in Belarus. It's difficult to squeeze it into 8 minutes, but I'll try to. Let me start traditionally of how relevant it is for the population of Belarus, with a population of 2 million, where about 160,000 elderly, and probably 80% require palliative care. It's a huge number, just colossal number. I'd like to say that the indications for palliative care remain the same, very much like everywhere indicators. Maybe legal framework, there's legal field. We need to work on legal acts, legal framework that nationally regulates. We need to set up a network and a structure of palliative care institutions. We should put in place infrastructure for supporting NGOs in social services. That's our helping hand in ensuring the quality of life of palliative patients. How to ensure the ongoing work and support for the system of palliative medical care. Staff, everyone who spoke before me highlighted that some have specialist, legally recognized specialty as palliative care specialists. We also are working on this in Belarus. And access and availability of these, not only drugs, I'm not referring drugs alone, I'm speaking about techniques and methods that are needed, we need to master to ensure quality of life. Well, legal framework could be endless, We would need many slides here. But this is the timeline, how we legally formalized palliative care. Starting in 2001, I'm speaking about palliative care for adults. Pediatric started in 1994, and everyone knows the name of Cherkov. I don't want to discuss it here because of lack of time. The very fact that in 2010 we saw the first protocol on how to treat cancer pains, and on top of that, it was amended by it was just a trick how to train physicians that they shouldn't fear narcotic drugs when they treat chronic pain in case where patient suffers from severe pain. In 2014, the first time that the law in Belarus legally recognizes palliative care. Surely, we may be late about other legal acts that regulate and in terms of just legal details, but still, I may say that the department that I led on the 20th of September, I'm just a fledgling head of the Republican National Practical Center named after Alexandrov in Belarus. I was appointed as the chief specialist for cancer care, but the objective that I face to set up before the new year the Republican Center for Palliative Care. This probably explains how many efforts went to make this possible. The new version of the law that came into effect last year expands the horizons of palliative care. They're focusing mostly not only on cancer patients only, no, they include all nosologies, all disease names and areas. This is huge progress for Belarus too. And our legal framework identifies the levels of providing palliative care across the country at large. We took a broader approach to the strategy of how to organize palliative care across the country. Why? Because surely we involve not only healthcare, but also social support ministry entities, NGOs too. NGOs, public organizations, several slides about the Red Cross of Belarus. I don't want to dwell upon an article that was published I will skip it for sake of time, and the very fact that legal acts were adopted that highlight the norms of palliative care, both at in-hospital as well as out-hospital setting. But I'd like to say that these norms are just recommendations, but they're legally recognized, but funding is provided for, like staff position on the payroll, especially bed provision in hospital. We're good about in-hospital initiatives, but as to outpatient setting, what is probably in greater demand and what is more important, this is where we are lagging behind. Mobile units are still very scarce, very much like we are short of qualified physicians, medical nurses, psychologists, and therapists, meaning psychology and psychiatric therapists. In terms of basic training, we have held a major discussion with our teachers. Why? Indeed, we traveled past this stage. Well, it's impossible. Or then, well, there must be something about it where you are in 2.5 stage, sort of. We are now working on curricula and synopsis, and we work in close contact with our colleagues to establish universal standards for training, both at the level of medical universities and medical colleges, as well as for refresher courses, for postgraduate courses. Thank you very much, Alexander, for the information you provided, that you've been doing it too. And I would like to thank you for sharing with us this information. In terms of post-Soviet space, I believe it's a great chance. Maybe we should like to say we need to standardize our support so that we should share the common glossary, that we speak the same language and the same topics that we have to tackle, especially when we talk about refresher course for postgraduate training. That would be super, really. And this is something that is just very, very, very sore subject. Should we be proud of ranking like 650 doses per day of SDDD? Well, nothing to be proud of. Of course, as is not enough. So this formulary that we have today, this list of drugs, clearly is. We're happy for our colleagues in Russia that they're well ahead of us. Although we remember the times where Guzil Rafaelovna might remember where Belarus was sort of leading the path, but it's a sort of scarce list, but we work on it. And we look forward to talk to this endocrine plant in Moscow. If they could provide narcotic drugs, probably that would help us expand this list. In brief, this law about Belarus Society of the Red Cross also saw some amendments and changes introduced about palliative care. It is now something that the Red Cross teaches, where they teach to professional medical nurses who provide care at home. Indeed, we have a large number of volunteers who volunteer to help at home. And this service has been very sustainable.
Wrap up, please. Sorry.
Yes, I'm wrapping up, sorry. So that is why the problems, yes, they're there. They're there. Let me show you the shortcomings and the problems that we need to tackle. But if we look at the resolution, we need to continue to focus on our legal framework. We must work to put in place a structure, meaning infrastructure. We must train how to provide non-invasive medication. Thank you, colleagues.
Thank you very, very much, Olga. Belarus certainly is a great example of palliative care development. I'm glad you're back in the palliative care fold with us. Our next speaker is Natalia Karafizi from Moldova. She's the executive director of the Foundation Hospice Angeles Moldova, a very important leading institution in Chisinau. So, Natalia, please go ahead.
Здравствуйте, я надеюсь, что меня слышно.
Good afternoon. I hope you can hear me well. Sorry, I have this technical glitch here where I cannot share my slides. I apologize for that.
We can see those.
That's great. So it is a great pleasure to welcome you all. Although we are at a virtual meeting, but I virtually hug you all and thank you very much for giving me the floor, even online though. We have been in touch since, I don't know, for an hour. We are on an hour online. It's fantastic to hear about your progress. It's fantastic to hear about your achievements, but this echoes with what we have here in Moldova. My first slide that I want to share with you, when we talk about effective national program for palliative care, we keep looking at this so-called triangle, right? Measures that are needed to ensure effective development of palliative care. At every stage, there are certainly either focus on national government pursued policy, or maybe it is education that comes to the fore, or maybe drug access and availability. But as you know, these three aspects of this triangle play equipotent roles, and one cannot go without the others. If we speak about the timeline of palliative care, I believe I would make no mistake if I say that there is an analogy in post-Soviet countries, because palliative care is a specialty in some countries, or it is a field that would evolve strongly in 21st century, when this sort of started to develop by leaps and starts, but it was finally reflected in legal acts. We started with NGOs, like very much everywhere else. And although we are in the 21st century now, still some legal acts are lagging behind or quite the opposite are there. If we speak about legislation only in the Republic of Moldova. The cornerstone change, the cornerstone decision that changed it all happened in 2012, where we saw amendments made to the national legislation that reflect three main ideas. First, law on opioids, be they weak or strong opioids, mild or strong, because not only oncologists could prescribe, which was the case before, but as of 2012, opioids could be prescribed by any specialty. They just need to be a physician, professional physician. Plus, per one prescription of medication, they may issue enough drugs for 30-day-long course of care. Besides, they can prescribe two drugs on the same prescription, one short-acting and the other might be extended release or long-acting drug. This came as a revolution because it was absolutely impossible in the medical world in Moldova. Speaking about access and availability, as my colleagues from Belarus in Russia highlighted, again, before 2012, we mostly had, for most part, injectable drugs, drugs for injections that had to do with strong opioids. Mild opioids were, for most part, tramadol and short-acting. Codeine, unfortunately, is still non-existent as a pure formulation. It is usually as part of co-formulation, but never as a dedicated pill in codeine. But since the amendments were made in legislation, we have finally seen mild-acting opioids, including extended release, and injectable morphine was complemented by per-os, by oral, short-acting and long-acting opioid, fentanyl patches, well, injectable in 2 doses, and methadone per-os for pills and as an oral solution. We are not making strong or weak opioids. Moldova, we import it from other countries. We are not a national producer. We don't have a single national producer in the country. As of 2010, we adopted the so-called national standard of palliative care. This is a uniform, one-size-fits-all standard for the national service. And in 2015, we adopted standards of how to evaluate and do accreditation for palliative care providers, because unfortunately, the existing institutions could not be retrained. They could no longer provide care and services to palliative care that would be adequate, would be professional, and at the level that was required. 2011 saw adoption of national clinical guidelines and protocols. These are their names on 4 main symptoms: pain control, pain management and cancer, palliative care, and caring for skin problems, and palliative of GI tract, dyspnea, and terminal stage. And it's 6 years after that, it was in 2017 when we realized that pediatric palliative care was badly needed. We adopted a national clinical protocol for this. And 2 guidelines were adopted, for most part, as an aid to family physicians, where a physician who is not really a professional dedicated palliative care, but he could consult, who could read up, or at least providing minimal control of symptoms to their patients. Surely, any legislative initiative, any legal norms that are newly adopted, this stands for funding too. Adopting a law alone is not enough. You see that in 2010, the national insurance system started to allocate funds to pay for palliative care medication. And we see 2 kinds of sort of palliative care here, financially speaking. The so-called palliative visit in 1 day, in bed day. As of 2016, 2015, you see that 1 home visit, it's cost grew from $3 to $10, and it's the price of one day in hospital rose also like this. And chronologically speaking, as of today, one home visit today would be costing $6, and the cost of one day in bed in hospital would be 20. So we are waiting for new tariffs to be adopted in October, because jointly for the next year, because jointly with the Ministry of Healthcare, we are now busy negotiating in making this sum bigger, because real expenses cannot be met, cannot be reimbursed by these nationally adopted tariffs. And cherry on the cake.
Please hurry up and wrap up your session. Your time is up. Sorry.
Yeah. Apologies, just the final step. The palliative care was finally added to healthcare system, fully incorporated. As to providers, we have two kinds, like I told you, at home and inpatient setting. Unfortunately, probably at home, we mostly have non-NGOs that tackle this problem. You see, we are more or less coverage. But as to inpatient stay, this is where, unfortunately, we still have only the south and north regions of the country that are more or less covered. And the most recent initiatives that each directorate should have a dedicated regional palliative care service, which would hold in place both at home as well as in hospital. And my last slide is to education. Unfortunately, both for nurses as well as for medical doctors, this legally recognized specialty is not yet recognized by Moldovan law, but curricula are there, both for students of medical colleges that would be nurses, as well as for physicians who attend medical universities. But competencies for physicians is provided only by NGOs as yet. Sorry for being overboard. Thank you.
Thank you very much, Natalia, champion for palliative care in the country. Our next speaker is from Kazakhstan, and many of us know her very well. Gulnara Kunarova is president of the Association in Kazakhstan for Palliative Care, member of the board of the International Association for Hospice and Palliative Care, and head of Together Against Cancer. Gulnara, over to you.
Так. Добрый день еще
Well, there
раз.
we are. A very good afternoon. It's a pleasure to see you all well and safe. I would like to thank the organizers for giving me the floor.
Я не могу включить
Sorry, I
демонстрацию.
cannot put my slides up. Thank you for giving me this opportunity to attend this important and representative meeting. I am speaking on behalf of Kazakhstan Association. Please, could we switch off all other mics other than the speaker? This is my presentation. I cannot put my slides up because somebody else has shared their slides, and I'm sorry, I cannot share my slides because somebody else is on air here. Sorry. Well, now I can, now I can.
Go ahead now, Gulnara, go ahead now.
Okay. Согласно
Okay, so as version 2 of the Global Atlas published by the World Alliance of Hospice and Palliative Care, as of 2020, Kazakhstan is part of level 4 of palliative care development. And among post-Soviet countries, we also have Russia, Georgia, and Ukraine. But we are perfectly aware that the gap with the leader countries is way too big for us to be, as the Russian and the English saying goes, be enjoying the bay leaf wreaths. So may I share with you, I wouldn't go back into history, how palliative care evolved in Kazakhstan in terms of, I couldn't rest on my laurels, yes, in terms of implementation of structure, how to train the staff, how to make drugs available, and how to set in place. Well, legal framework, this is it, in the funding and the policies that are adopted, and readiness and openness to constructive dialogue with the professional community. Last year alone, we adopted a novel code on the healthcare of the nation, which included novel definitions of palliative care and palliative medical care, including palliative medicine. I don't want to quote it, but what is a matter of principle here, that palliative care now includes the family and caregivers, and also mentions medical services as well as specialist social services, including psychological and social support as well as spiritual support. Palliative care is provided as part of the single standard that was adopted last November. It is a great improvement compared to the prior version, but we are not very happy with our legal framework. We think a lot more has to be done about payroll, about staffing, about educational standards, and you name it. Palliative care is part and parcel of guaranteed benefits package. This is something that is paid and picked up by the budget for healthcare and in part from the social development and well-being at the Republican and local budget. Whether it suffices to pay or not, it's difficult to say because it's fragmented, it's not transparent, and surely we may see inefficient use of funds and probably tariffs that are way too low. It is part of medical services now legally recognized at the outpatient setting too. I would like to thank Astana Declaration and the National Plan to Control Cancer Diseases also provides for funding of mobile units and training for these mobile units by associations of palliative care, and Kazakhstan National Institute of Cancer and Oncology and Radiology. As a professional organization, we're a stakeholder at each and every discussion, but we would like to see the government more open, Ministry of Healthcare to be more open towards us. Access to opioids, this is our disgrace, and this is something that has been greatly troubling us. So they are, of course, free of charge, for sure, but since 2019, this is something that has to be insured by the single distributor from SK Pharmacy. We used to have different funding system. This removed many technical bureaucratic barriers and you name it, but it identified a number of further barriers by medical institutions and physicians among strong opioids. Unfortunately, what is now available are injectable morphine and fentanyl in patches. Morphine pills, which local pharmaceutical company struggled to work, is not available now. Why? Physicians are not aware of this. They do not prescribe, and they were not procured for, and they had to just burn it literally. But it is locally produced. We could resume it at any time when conditions are in place and public awareness is enhanced. I believe we need to include an item on our resolution, on our declaration, about an interaction with Moscow endocrine plant and our cooperation there. In outpatient setting, our formulary there for this national standard of government-picked bills, it has 17 drug names, including these 3 opioid analgesics, in 1 medical device there too. 11 clinical protocols have been adopted as of today. They were revised or drafted back in 2013, and many of them are revised and have been revised. Others are still waiting to be revised. In order to get care in hospital, this can be provided to hospices. We only have 9 across the nation, and in palliative care and supportive care units that every and each of 19 cancer dispensaries, as they're known, that are available there. Other patients may be at hospices, or they are put into palliative care or nursing in general hospitals or in specialty hospitals. In terms of number of beds, 989 beds are allocated to this, but as the novel standard says, 10 beds per 100,000 population. It means that the need in beds has been we met half of this need. But there are dedicated beds for social institutions. And many of these, 113 social, like old age homes, something where we have about 2,000 patients of these who are senior citizens or patients with incurable disease. At the outpatient setting, well, what we have here, mobile units, mobile teams. So far, mobile teams only serve us at home, cancer patients only of clinical diagnostic group number 4. But we now have 220 mobile units set up as part of this cancer plan. It means that the budget is allocated through this onco plan and is picked up. The amount of care that is provided may differ greatly from one region to another, but we're just taking first steps and we hope to grant more or less uniform standards. We're yet just supported by oncologists only, but we are seeking to develop it further. And what palliative care is not licensed in Kazakhstan, which certainly poses great problems. As to training, how to train, palliative care is not a dedicated specialty legally, but as of last year, specialization of hospices is now been legally recognized, but it only applies to physicians. Unfortunately, nurses, there is no specialist, meaning recognized by the law. National educational standard for the first time included 120 hours for colleges and 180 hours that need to be lectured on palliative care. Also, we see practical hands-down course, post-graduation as part of internship or rather residency in Western terms. And in residency, not have internship and residency, okay, for that many hours. For oncologists, pediatricians, and gerontologists. I'm sorry, I'm not tracking the time. Berries are certainly there.
You hit your time limit, so please do summarize and wrap up. Thank you.
Okay.
Thank you. Yes, barriers, I suppose, to some extent, they probably apply to each post-Soviet country, so I don't want to dwell upon them in great detail. I do hope we will enjoy this opportunity to discuss it in greater detail, all in each aspects where we can cooperate together, where we should work together. And in newly adopted resolution, as I hope this declaration will reflect it, very much along the lines we're discussing now. Thank you very much. Thank you for your attention.
Thank you very much, Gulnara. Excellent leadership for your country. Our final presenter today is Dr. Zafar Husanov from Tajikistan. He's Chief Oncologist of the Ministry of Health, Director of the Republican Cancer Center and at the Ministry of Health in Tajikistan, where they've made considerable progress. I've spent a good amount of time there. Zafar, over to you. Be sure to unmute. Unmute yourself, please.
I apologize for that. Yes, it's now on, right? Well, now we are on. That's great. Dear colleagues, dear attendees, dear friends, allow me to welcome you all at the 17th Congress of the EAPC. And I would like to use this opportunity to extend my words of thanks to the organizers. And my greatest thanks go to Stephen Connor, a longtime friend and a champion of palliative care in Tajikistan. To Diana Nevzorova, special thanks Julia, Eric, and of course, I would like to extend my gratitude to a great friend of ours and a great teacher of oncologists of Tajikistan, to Sofia Michelson. I'm sure it will be very fruitful. In this form, it will be adopted further, as it will justify our expectations. One fact needs to be pointed out that today we are flying into outer space. Russian actors are now sent to outer space, and cameramen to make films, commercials. So it is something very encouraging. The very fact that it is developing by leaps and starts. And finally, we hope to live to see the day where we'll find a cure all for cancer, panacea for cancer. In our discussions on palliative care to patients will remain as past, as it will become history. Before I begin my presentation, allow me please to remind you a historical fact. For the first time, at CIS countries, congresses first included palliative care dedicated session at the 6th Congress that was held in Dushanbe at the initiative of Tajik oncologists, and Stephen Corner served as moderator there, if I'm not mistaken. Given that today this event has what we are very limited in time, I would not dwell upon statistical data. You can please look up my slides, because everywhere in the world there is a trend to rising figures in terms of morbidity and in terms of incidence. So, for the first time, palliative care became the subject for discussion back in 2009, where a national program was adopted to prevent and treat cancers and diagnose cancers. And objective number 4 in that program was laid down as to improve the quality of palliative care to patients with malignancies. Support by the state, by the national budget. We first adopted government decrees back in 2017 only, and the code that was adopted regulated public relations in healthcare, seeking to implement constitutional exercise for the exercise of the right of our students for healthcare. The Ministry of Healthcare and Social Services adopted a strategic plan on developing palliative care nationwide and primary medical care in Tajikistan, where item 3 says that we need to improve integration and provide basic services, including palliative care. We developed and approved model regulations and social assistance centers under executive bodies of local self-government. This is something that was adopted as an order, meaning executive order adopted by the National Ministry of Health. It says that, amongst other things, it has to provide palliative care. And many people in Tajikistan now have forgotten about this. Well, palliative care provision. We are seeing the specific weight, if you will. Apologies. Yes, here is my slide. Of the cancer patients, we now see how many. We grouped together the barriers. We estimated the needs in the number of dedicated palliative beds, and we provide methodologically effective model for palliative care to cancer patients. As we addressed these objectives, we realized that rising incidence and rising mortality makes it urgent to develop the model for palliative care. And we should seek to overcome the existing barriers, recalculate our estimates of bed capacity. We need to provide and adopt national protocols and guidelines for pain relief, and provide care to cancer patients that seeks to improve the situation here in my country. What are the barriers in palliative care in Tajikistan? First of all, no registries are available to provide care at the national level. That hence we cannot estimate the real needs. Stereotypes and fears of general practitioners who have the authority to prescribe narcotic drugs, but they are very apprehensive. Incomplete provision of palliative care we are short of trained psychologists and social workers. So we came forward with this model of care. This work was led by the Ministry of Healthcare for these 4 years, and we set in place different standards of palliative care across the country. We divided them at 3 levels: Republican level, municipal level, and regional or district level, if you will. Well, in all these levels, Republic or national-wide level, in Republican Cancer Center, we have set up 2 specialist units for 8 beds and day hospital that has 2 beds. Regional or district, they have dedicated units with 2 beds, dedicated beds, and central regional hospitals in each district also has to have beds, dedicated beds for palliative care. Training programs, educational programs for palliative care, 8 colleges, and postgraduate training. We have set up a module for 36 academic hours, and the trainees have to pass an exam. And Tajikistan National Medical University, as of September 2013, has adopted a curriculum, in its curriculum included a program of palliative care, which was non-existent before 2013. It is now a mandatory subject, and the trainees will sit for an exam. Palliative care at the end of the course. Palliative care is a mandatory subject, and the students again sit for an exam and pass it, need to pass it. This is a number of hours that are taught at medical universities. We do have a national institution, which is known as Republican Educational Clinical Center for Nursing, and palliative care for adults are a part and parcel of certification issues for nursing staff in postgraduate refresher courses. All these programs and all these teaching courses, be it for nurses or physicians, are based upon best practices and guidelines adopted by ELNAC and EPEC. We have set in place legal framework on palliative care, and for this model, we adopted universal standards of palliative care provision across the country. We developed clinical protocols on how to treat pain syndrome. Yes, I realized I'm short of time. We now have specialist videos that are posted. In one of the ways to ensure better access to opioids, we now registered morphine tablets, which were not just available in the country. And these are the steps or the stages, if you will, that we need to travel and have traveled in providing palliative care in the country. And this is the Republican Cancer Research Center. We spoke about these 2 dedicated beds that are properly equipped to provide palliative care. And this is our day hospital where we provide care to patients using
Okay, thank you, Dr. Zafar.
disposable. Yes.
Thank you. Good to see you have an interdisciplinary team there. That's great. Good. Thank you very much. Very good. Well done. We are running over just a very few minutes, if you just bear with us. Thank you. Appreciate all these presentations, but I really would like to have Dr. Nevzorova give some final comments, and then we want to do a poll to take a vote on the declaration that's been put into the chat. Thank you. Over, Diana.
Dear colleagues, and Stephen, thank you so much for giving me the floor. Indeed, my colleagues and I have drafted sort of a presentation, but it's probably worthwhile to mention that what is the most important thing as we see it, dear colleagues. I want to highlight some points, some items in the declaration, because it's declaration of intent. It's now in print. Please revise it. And the most important thing, as I see it, because this is something we would like to discuss and we would like to think along these lines, As you are perusing this declaration, can I give you a couple of minutes for that? And we will have an online vote. The organizers gave us this opportunities and we will look at the statistics. May I right now say that this declaration is beyond politics. It's beyond political decisions. It seeks to serve the needs professional community and patient-centered organizations and patients organizations. These are legal matters and work in palliative care that shares common plans and common needs. And we're speaking the same language, we share the same philosophy to how to provide care for incurable patients that are near and dear. We're beyond politics. We speak the same language. All those people in this ward who work in the home of dying patients, they know what the problem is, where the truth is. We do know what words we need to choose when we talk to government officials. We know the needs of our patients. We tried to draft our declaration so that we could discuss it today with the presenters. Of course, it needs to be finalized, and I invite you to please use this on the 2nd of November on our site. We will be discussing, we'll have like hybrid when we'll discuss both at the website of such university. Some will attend in person, others online. I would like to thank those who plan to travel to Moscow. And certainly you will be able to log in online. We will share a link with you into our chat. So please join us, dear colleagues. We would like to say, we are not speaking about CIS or about Russia alone. No, Russia doesn't seek like to lead here. No, we have common problems. We are people from different countries, and some of them are not part of CIS, who are part of our chat. So please revise whether we are ready to join forces into the professional community so that we should seek to improve educational standards. We should work hard to make greater access and availability of painkillers, and our professional community should work together to come forward with educational standards as we seek to revise guidelines or standards of care, including, amongst others, medical healthcare workers, professionals, and volunteers who are not medically trained. I do not want to discuss at large the things that I drafted in my presentation for today's meeting. I would much rather instead tell you that we all took the first steps from some people who come forward with the initiative, who help push this forward with some education, who were the trailblazers, who started teaching, who just saw these huge problems and huge barriers that stand in the way for executing our patients' rights, who have the right to healthcare. We're saying that in Russia, over 1,200,000 people who need palliative care in Russia, but only 700,000 get it in Russia today. Of course, we are saying that a lot has been done, but we cannot claim that each person who needs it in Russia, he may get access to this care 24 hours a day. Although Association of Hospice Care has held a huge number of educational events, over 18,000 medical professionals attended some professional courses, and we have publications and whatever. I don't think it's time for us to stop and rest on the laurels. I'm so happy that we now chat, we discuss further cooperation. Thank you, dear colleagues. Let's start a vote now. I think this is what is important now. And on your screens, you will now get this opportunity. And please highlight your choice. Vote yes or no. And once your voice is accepted, this education window will disappear. And we can, and I very much hope that our technical staff will help us, we can immediately see the votes as it goes. Where the votes go. So do you vote for adopting the declaration? Say yes or no. I draw your attention that the organizers and members of the group, today's presenters, have no right to vote. This is how technical service arranged things for us today, but we are very much in favor. We are very much in favor. So please, and we do hope that you would support our initiatives here and our colleagues who are logging in. So please, dear colleagues, please vote so that we could carry on. Yeah, I can see the votes coming. However, on the screen, of course, this is voting for the declaration, which may well be amended. And we very much like to suggest, if possible, the final version of this declaration. We suggest that it should be signed at a Congress on the 2nd of November in Moscow. It's important that we should take a decision right now, whether we need it or whether not, whether there is probably no need, as some people might think. But anyone who attends today's session, all our audience may take a vote. Please do, dear colleagues, other than the speakers. Now, in our chat, if information is provided for registration for the online conference on the 2nd of November and 2nd of November roundtable to discuss palliative care in CIS in post-Soviet space, please, dear colleagues, please join us there. It's free. Please, you can attend, come in person, or you can join us online. We hope we'll have more time, more opportunities to plan our further joint efforts together.
It appears to be a unanimous vote so far. In favor.
Похоже, Stephen, I don't quite see you. We are seeing a problem in this chat, or should we write, or what? I'm sorry, the lecturers can write their choice. Only lecturers now can write in chat, and specialist chat for lecturers. This is the organizers and others can also vote, but they in chat. So I look to hear about this information. Yes, half of our attendees voted already, have voted. Please, we urge you to please, yes, we can see now the figures. So distinguished participants, please vote. Yeah. Stephen?
Yes. Well, sometimes this happens.
I can see that it's not only members of our group voting. It seems like our audience are voting too. That's great.
Well, some people may have trouble accessing the poll. This sometimes happens with attendees, depending on the type of computer or phone they're using. So I think we can accept this as the result. It's 64% participation among the attendees, all 100%, 50 of which voted yes, 50 out of 50. So I think we can say that the resolution has passed, the declaration. And we have a record with tape of all of the votes, including the panelists. So in the interest of time, Diana, I think we should just wrap up now. We have another pre-Congress webinar coming up shortly. So, but I want to thank everyone for your kind attention, the comments in the chat. I think this has been a historic event for the region and something that's really helped move us all forward. But as was noted by several speakers, the work continues. There is much more yet to do. Diana, any final comments?
Дорогие коллеги, я хочу всех, прежде всего всех благодарить, потому что я слышу почему-то и сейчас я попытаюсь.
Sorry, it was interpreter's fault who just malfunctioned. So I would like to thank the attendees as well as the organizers, and Julie, you As the host of today's session, thank you very much for making it possible. And most importantly, I would like to thank everyone for caring, for your commitment, for huge work that you're doing. I do know that many of our organizers and lecturers who are just in another time zone, they are on another continent. They have just early hours of the morning. We so much appreciate that you're ready to be up so early to make these sacrifices just to join us. And I do hope our cooperation would continue. I do hope we'll move forward again. We have somebody to care for. Adults and children have the right to care. And we as professionals, if something that we can do, we should do it. We should do our utmost. Our professional community is in very difficult conditions, but we're working, not just interacting with our government officials and leaders who may not be fully aware of what we do. But we're working hard. Thank you very much, dear colleagues, for being champions of this course. I look forward to seeing you on the 2nd, and I hope for further joint participation. Thank you so much, dear colleagues. Thank you.
Thanks, everyone. Have a great day. And take care, be safe, and do good work. Bye.
Спасибо
Thank you.
всем большое.
Goodbye. Thank you. Thanks to everyone. Till we see you on the 2nd of November. Thank you so much. We're logging off. Thank you so much. Goodbye. Thank you, dear participants. All went so well. Thank you so much. We wish everyone a very good day. Thank you so much. Thank you so much.
Ася, все хорошо.
Да, все хорошо, Наталья Михайловна, спасибо вам
Наталья
огромное.
Михайловна тоже, да, переключались. И было слышно, ничего, все так это все так по-нашему, по-паллиативному, когда все именно в живом режиме, таком каком-то нормально человеческом, вот, и все хорошо получилось. Да, вам спасибо
Спасибо и
огромное.
вам.
Всего доброго. До свидания.
Всего доброго.
Ася, я нажала сохранить куда-то в облако. Куда это я не